Ashley. Good afternoon, everyone. My name is Carol LaFleur, and I am the Executive Director of the XLH Network. On behalf of the network, I want to thank all of you for taking time out of your day to be with us. This is certainly an exciting time for the XLH community, and we so much appreciate the opportunity to talk with you this afternoon. We have assembled a great group of presenters for you today, and we know that you're anxious to hear from each of them. Before we get started, I do want to go over a couple of housekeeping items. First, a thank you to Ashley and Global Genes for hosting the webinar for us today. We appreciate very much your help and support. And thank you, too, to everyone that sent in questions on Facebook and through email. It was great for us to know what you wanted to hear the most about, and our panelists have worked very hard to incorporate the answers to all of your questions into their remarks. If you do have a question, as Ashley mentioned during the presentations, please use the Q&A function that you see on your screens, and we will do our very best to address it. Because time is limited, we want to be very careful to not be repetitive. So if I could please ask for your help in making sure that we are not asking questions of an item that has already been presented. We appreciate your help with that. Also, if for some reason we don't address something during the time allotted, you can always email it to us, and we will do our very best to get an answer for you. We are also recording this program, and we'll have it available on our YouTube channel. So if you have loved ones that were not able to join us today, that it will be available online shortly. Thank you all again for being with us. It gives me great pleasure to introduce our first presenters. Dr. Thomas Carpenter is a professor of pediatrics and professor of orthopedics and rehabilitation at the Yale School of Medicine. After undergraduate studies at the University of Virginia, he received his medical degree in general pediatrics training at the University of Alabama. His fellowship training in endocrinology at Boston Children's Hospital began his career-long involvement in clinical research focused on metabolic bone diseases in children. He has been at Yale for over 30 years and has been very active in the Yale Bone Program throughout his time, including the direction of the Yale Center for X-linked hypophosphatemia. He has authored over 15 articles, reviews, and book chapters related to metabolic bone disease in children. Dr. Carpenter is also a member of the Scientific Advisory Board for the XLH Network. He is joined by Dr. Carl Insogna, who is the Ensign Professor of Medicine and Endocrinology at Yale University. Dr. Insogna began his clinical research studying XLH and was the first scientist to show evidence for renal phosphate conservation in patients with this disease, despite the known defect in renal tubular phosphate reabsorption. His spin XLH have continued uninterrupted over the last 30 years. He has worked closely with Dr. Carpenter in pediatrics to explore natural history of XLH and to develop new therapies. He's lead investigator on the ongoing international study that has led to the recent approval of Crysvita for the treatment of adults with XLH. We are pleased to have both of them with us today. Dr. Carpenter and Dr. Insogna, please take it away.
And it's a real honor to be part of this overall effort, and I'm happy to be here together with Dr. Insogna to help allay any fears and to hopefully provide some explanation as to what this medication is about and what people might expect as approval has occurred and the widespread use of it will be beginning. I don't know how to control the slides, but I think we could just go to the next slide. Thank you. The purpose is to tell you exactly how LH happens and how it works, how the drug works. I'm going to review this slide, which I think is probably best started in the left panel of the slide, in which there's a bone listed, and that bone, XLH, has cells in it that extremely high amounts of FGF23, and this gets its way into the circulation, and then you can see the two arrows that go from the bone go as to the right, a consequence of that high level of FGF23 in the circulation is to reduce the machinery in the kidney, referred to on the slide as NAPI2A and NAPI2C, that help the kidney retain phosphate. And when the machinery is deficient, noted by the red arrow, urine excretion goes up. You see on the other side of the kidney with the increase in phosphate excretion with the red arrow. And as you follow the path around, you will see that that is the main reason that the serum phosphate level is decreased. We go back to the bone and we take the left path, we will see that the machinery that activates vitamin D, the 1-alpha hydroxylase, that decreases, and with a reduced amount of the activated form of vitamin D, which is listed in a slide as 125-OH2D, that reduces the amount of phosphate that you absorb from the intestine. And this, too, then, as you follow the path around, is a contributor to the low serum phosphate level. And as you look and see, the low serum phosphate level goes back to the bone, and that's actually the reason that the bones become rachitic. Finally, if we look in the upper left corner of the slide, we see the mutation that occurs in XLH listed, and that mutation in the gene called FEX is the regulator that results in those high levels of the bone cell production of FGF23. As you see the expansion on the right of the kidney, a cell is shown that it's the cell in which the work is done to reclaim the blue crystals, in this slide the phosphate, back into the body. So the central pipe of fluid that becomes your urine contains phosphate, and those flat cells have reduced amounts of that transporter, NAPI2A or NAPI2C, and the phosphate can't get in the system. On the right side of the cell, where the cell interfaces with the blood, you can see picture FGF23, all of which have to interact with this green-purple colored complex to effectively tell the cell to make less of that machinery. You can go to the next slide. I'm going to turn the narration over to Dr. Insogna, who's going to tell you how FGF23 antibodies can impact the system.
Good morning or good afternoon, everyone, depending on where you are. I, too, am pleased to be part of this, and hopefully we can answer some of your questions and clarify any concerns or uncertainties you have. Tom just summarized for you basically how this disease develops. Two things are important to recognize. First is it's a hormonal disease. Surprisingly enough, the bone is a hormone-producing organ, and it makes this hormone FGF23. He just described to you, it causes you to pee out too much phosphate, and it causes you to not absorb enough phosphate in the intestine, and the combined two effects lead to lifelong low blood phosphate, and that leads to rickets in kids and problems with bones in adults that we'll get to. And basically what this drug does is to abnormalities by blocking the actions of that hormone. So the people in Japan, not at a brewer company, had a pharmaceutical division, and they developed an antibody, which is a substance normally made in our bodies to block infection. But in this case, they made the antibody to this hormone. And they did it cleverly enough so that it blocked the hormone to your blood phosphate normalizes. And basically, what this slide shows you is the antibody, which, if you look in the upper left-hand corner of the left-hand panel, you get a purple sort of Y, and that Y is the cartoon of the antibody because, in fact, they have a Y-like structure at the atomic level. But basically what you see is it's gliding onto FGF23, which is that squiggly blue thing. And it does that. It essentially reverses all the changes that Dr. Carpenter described. By blocking the extra hormone that's in the blood of patients with XLH, it allows the kidney to start reclaiming phosphate. Claim 90+% of the phosphate we pee out, and even if you don't reclaim a little bit of that, it makes a problem. So it basically lets you start reclaiming the phosphate that's rightfully yours, and by doing so, raises your blood phosphate. At the same time, it improves calcium absorption, phosphate absorption in the intestine by making the allowing the body to make the active form of vitamin D that's required for absorption of phosphate from the gut. So it basically does reverse the two things that Dr. Carpenter told you were abnormal in this disease. It raises the ability of the kidney to reclaim the phosphate. It improves phosphate absorption from the gut. And together that raises the serum phosphate. It is critical that the body have enough phosphate to take normal bone when a child is growing and to repair and renew bone in an adult. It's one of the two essential of bone. The other one, obviously, as most of you know, is calcium. So calcium and phosphate are the mineral ions that make up the constituent of bone that we think of as the hard bone. So if you don't have enough phosphate, you just can't make bone when you're growing, and you can't repair or make new bone as an adult. This is quantitatively and qualitatively different than what we've been able to offer all of you in the past, which is calcitriol and phosphate. The problem with that therapy is it doesn't correct this abnormality. So when we give you phosphate, it's like pouring water into a bucket with a hole in it. Up the phosphate a little bit, but then you just pee it all out because you're not correcting the problem in the kidney. We give a triol, which is the active form of vitamin D, but we can't give it to you in nice, smooth amount. We give you 1 dose or 2 doses a day or maybe 3, and the calcitriol levels go up and down, and the phosphate levels go up and down, up and down. It's not like your body doing it for you, in which case things are nice and smooth. So the difference, unlike our herky-jerky therapy to date, this therapy allows us to normalize these abnormalities in a nice, continuous, smooth way.
We can go to the next slide. And, this data for the application of that antibody to in the first Peterik study that many of you that are on the line had children that participated in. And on this slide are the two groups that were randomized to as they entered the study. In the blue line, you see the adults from children who were assigned at the beginning of the study to get the injections of the antibody every 2 weeks. In the green line, you will see results of the children who were assigned to get the injections every 4 weeks. I should start with the middle panel, which shows the serum phosphorus levels are, and look across these. You will see on the x-axis that all the numbers are divisible by 4, and that is when everybody came in to get their injection. So other than that very first point, which is actually in between the 0 and 4 points, all of the just about these points are at the trough of the action of a 4-week cycle. So if you look at the middle panel, you see in the green line there's an initial 2-week increase in the phosphorus level, but then by 4 weeks it's down. And there's actually a 6-week point in there, and so we're getting a phosphorus level at the time the activity of the is at its highest about 10 days to 2 weeks after the injection, and then we're getting it at its lowest, which is just before the next injection at those every 4-week intervals where the dots line up with the hash marks on the bottom of the graph. And you can see in the green line there's kind of a sawtooth pattern reflecting that that activity of the antibody as it is higher at the 2-week point and goes down. In the blue line, patients that got the dose every 2 weeks, you can see a steady state serum phosphorus. Now that gray area in the background is the normal range of the phosphorus levels, and you can see baseline at the time 0 point, everybody was hypophosphatemic, but then as they got the medication, they rose and they stayed even at the trough levels and all in the normal range. So this exactly tells us the of what Dr. Insogna just described, and that is when you can have machinery that is responsible for the phosphate, independent of having to give these large doses and seeing most of it go out in the hole in the bucket, you can actually see a nice response in terms of fixed serum phosphorus level. And this happens is because that kidney threshold changes, and that's shown in the very top panel of the slide. And you can see the 2-week versus 4-week change in the blue versus green colors. But nevertheless, the reason that serum phosphorus level is going up is largely in part to the curve of the kidney is working. In the bottom panel, you can also see the increases in the activated vitamin D levels that occur, and in that the blue and the green graphs are a little bit more aligned with one another. There's a little bit less of the down pattern that we saw with the phosphorus. You can go to the next slide. What does all that mean for the bones? And if we look on the right, we will see an example of a child who entered the study looking at the x-rays. This is a knee x-ray, and in the baseline x-ray of the knee, if it looks as you approach the center of the knee, you can see some uneven space where the bone is not completely filled in, and some irregularity and curvilinear maladies of the area where this it's called the growth plate is, and these X get scored by a guy who has not seen any other data in the study and doesn't know anything about the order that the X-rays come in or what, and he gave this a severity score of 3.5 under word baseline in the slide. And after 40 weeks of the antibody, these X-rays were repeated, and you can see some of the defects beginning to fill in and healing going on, and the radiologist gave this a score of 1, decrease in the severity score of the rickets. And then far right, later, after 64 weeks of exposure to the antibody, the X-ray is considered entirely normal. There's a severity score of 0, and if you look at the X-ray itself, all of those defective areas have started to mineralize, and it really has the configuration of a normal bone. Now, this is one patient, so if we go to the left side of the screen, you see what the average of all the patients was at baseline, which is in the gray, and at the 40-week point, which is in the kind of rose color, and the purple represents the 64-week time. And on the left of those are those patients that got the drug every 2 weeks, and on the right, those that got the drug every 4 weeks. see that in both groups, the it was dramatic after 40 weeks, and it really stayed away and improved even a little bit more in the Q4 week group, longer treatment, so that this really represented a sustained way of managing this disease. And the overall score began 1.5 to 2 range, came down to in the 0.5 to 0.75 range over time. Not dramatic as the single example that we show in X-rays, but that's just to give you an idea of what these numbers all mean, and show also that the serum phosphate level, then you get these concurrent changes in healing of the skeleton for the very reasons that Dr. Insogna pointed out to you, that you need this combination of minerals to make the bones mineralize. I think the next slide. And childhood outcome that was important was growth, and people grow at different ages and at different levels of maturity. So we standardize the measure of inches or centimeters to what's called a Z-score, which is an of everybody of your sex and your age, and Z-score would be, 0 at that time. And if you get a Z of 1 in a given interval, you've actually increased from, say, you started with a Z-score of 0 from the very average or 50th centile for age up to almost the 70th centile for age. So it's really a single increase in a 1 Z-score would be remarkable. You can hear the change in the Z-scores over time in the 2-week interval treated patients and the 4-week interval treated patients. And if you go out to the very end, you see that over roughly a 48 to 64 period of time, there was an increase in Z-score of almost 0.2, which is a significant change in centiles in the every 2-week treated group. And a similar trend in the Q4 week, although it didn't get numerically quite as high, the direction was still very positive. So this translates to the fact that people are increasing their height percentile. They're not just growing, but they're growing faster than a normal rate over the period of time of the treatment. You could go to the next slide. Is the adult data, which I'm going to turn over to Dr. Insogna.
So the adult study was very similar to the child study, but there were some important distinctions. Because therapy in adults, conventional therapy, is controversial in terms of its benefits, the study enrolled adults the ages of 18 and 60 who were symptomatic, that is, had complaints of pain or stiffness that was objectively measured on a questionnaire, essentially. The second thing about this study was that it was what's called double-blind first portion of the study. So the information I'm going to show you is from the first 48 weeks of the study. In the first 24 weeks, half the study subjects received a injection, a placebo, and half received burosumab. And nobody knew who was getting what, and that included all the investigators. So it was double-blind to determine whether one could objectively decide whether this drug made people feel better. In general terms, there were 3 outcomes of the study that will be of interest to you. First is, did it correct the low blood phosphate? Did it make people feel better? And as a consequence, did it change their use of pain medication? The third is, did it improve their bones? So as I'm sure many of you know, conventional think that after a child reaches their full growth, there's really no reason to continue therapy. But we know that in adults, terrible complications arise from this disease. Then problems with abscesses continue, fractures occur, and particularly calcification around joints leads to a loss of mobility. And all that, you can have hearing loss. The disease progresses after a child stops growing, and we know that some of these complications are approved with conventional therapy, but we know the conventional therapy doesn't prevent or cure all of them. The slide basically shows you the effects of the drug in sort of two phases. If you look at the dotted blue line in the middle of the slide, that divides on the left the double-blind portion of the study, where half the study subjects got the placebo injection and half got Barosum. And the right half of the slide shows you the half of the study where those patients who were getting the placebo got to active drug. So it's at the blood phosphate values, and the horizontal dotted black line is the lower limit of normal for blood phosphate, and this shows you the blood phosphate values in the middle of the dosing interval. On the kids, all the adults got the drug every 4 weeks, on an adjusted basis, starting milligram per kilogram body weight, and a kilogram is about 2.2 pounds. See that immediately upon receiving the drug, if we look at the green line, the subjects who got the Barosumab, which are shown in green, on average, rapidly normalized their serum phosphate, and it stayed normal for the first 24 weeks, and it remained normal in the second 24 weeks. Placebo group shown in the black triangles were below the normal range, and when they got placebo, they never normalized their blood phosphate, and as soon as we switched them over at the 24-week point, shown again in the dotted vertical blue line, as soon as we switched them over, phosphate on average normalized in everybody. So just like in the children, this drug rapidly and effectively normalizes blood phosphate. The number on the bottom just show you the percentage of subjects who achieved the target, which was a blood phosphate above the lower limit of normal 2 weeks after getting their last dose. You can see that in the first 24 weeks, which is shown in the, I'm looking now at the bottom of the slide in the brown and light brown table. In the first 24 weeks from 0 to 24, those subjects who got the placebo, only 7.6% achieved that normal phosphate, and 94% in the Barosumab treated group. You can see that in the second half of the study, shown on the very last line, in essentially 90% of the subjects who switched from placebo to Barosumab now got a normal phosphate, and 80% who continued on Barosumab continued to have a normal phosphate. Can you go to the next slide, please? Okay. So this shows changes in physical function. There are 3 outcomes that were looked at. One was stiffness, one was pain, one was physical function. And I think this is very instructive. You can see that in the first half of the study, the subjects who received Barosumab, again shown in the blue line, are showing an improvement in physical function. As the line goes down, it means an improvement. You see that the group in the gray line, again we're looking at the left-hand side of the slide, showed no improvement in physical function. But difference between those two at 24 weeks by standard statistical criteria did not quite reach statistical significance. And the other 2 measures, which were pain and stiffness, both showed towards significance. Because of complicated statistical analyses, only the stiffness was significant. So this shows you how important it is to have a placebo group. Obviously, there are improvements here. Now, when we switch everybody to active drug, the gray line, as you see, now continues as a dotted green line, and they rapidly get better. That's because they got the drug, but they also know that they're on the active drug at this point. There has to be a component of placebo effect. You see that the group who received burosumab in the first 24 weeks continue to show an improvement. I think that's reassuring. I think it shows you that with continued improvement, with continued administration of the drug, there's continued improvement in physical function in folks getting this drug. Please. I think is probably one of the more important endpoints of this study, which was to look at how well fractures that people had at the beginning of the study, either partial fractures or complete fractures, healed during the study. So as many of the adults on the call know, people suffer from these little mini fractures. We call them pseudo fractures. The fractures can occur particularly in the legs, bones in your legs and in your feet. They can cause pain and can progress to complete fractures. Started the study, complete X-ray survey in everybody to see how many fractures and pseudo fractures they had, and then we looked at those serially over the course of the study. And something that is not influenced by what drug you think you're getting, right? It doesn't matter whether you think you're getting the active drug or not. Your bones are either going to heal or they're not. As you can see in the first 24 weeks, the green line, which is the burosumab treated group, but a much greater percentage of healing, nearly about 44% healed, while the placebo group shown in the gray line really showed no healing. And then very significantly, when you switch the placebo group over to active drug, they showed a rapid increase in fracturing that paralleled the line in the group receiving burosumab, continuing to receive burosumab, shown in the solid green line. So these are very objective data that in fact, at 48 weeks in the placebo-treated group, the percentage of people that had healed at 40 weeks, in other words, they had only gotten active drug for 24 weeks, was about the same as the percentage of people who had healed at 24 weeks in the burosumab group. So it really gives you confidence that this drug is doing something really good to bone by healing the osteomalacia. That is, healing the problem in bone healing in bone function in adults. And we've actually done bone biopsies, which we're not going to show you the data from. It also confirmed that if you look under the microscope, the problem in the bone with healing of normal bone is going on with this drug. The last slide. What am I looking at? Just shows you an example of a typical pseudo fracture. So on the left is a patient who clearly has had a rod placed in their left femur, the nail placed in their femoral neck. So then you can see it's going up into the ball and the socket in your hip, and then the rod is going down the left femur. And you see in the blow-up that there's a fracture line that extends right across the middle of the image, extending right across that side of the bone, the cortex. Weeks when we X-ray that line is gone. So this person healed that fracture very quickly. And a couple of patients who have had surgery during this for osteotomies during the trial, and the orthopedists have commented on the fact that the bone looked like it was healing much more rapidly than is normally the case in patients with this disease. After this, I think there is. Oh, so the one other point I'll make in closing is that I'll show you the data. Impressively, people who were in this trial wound up using less pain medicine. And what was interesting was in the first 24 weeks, they couldn't change the amount of pain medicine they were getting. But in the next 24 weeks, in the open label portion of the trial, they were allowed to. And in the first 24 weeks, no one changed the amount of drug they were getting on average. But in the second 24 weeks, there was 60% reduction in not only non-narcotic use, but actual narcotic use. That certainly suggests that people were having less pain. And that was reflected in their ability to reduce their dose of medications. And we didn't ask them to do that. We told them that they reduce their dose. They did it on their own.
Great, Dr. Carpenter and Dr. Insogna. We know how hectic your schedules are. We appreciate so very much you taking time out of your day to be with us this afternoon or this morning. Our next presenter is Paul Elfin. Paul is the Senior Director of Patient Services for Ultragenyx Pharmaceutical. He has a social worker background and enjoys assisting patients. He's been in the biotech industry for the past 17 years and has spent that time supporting rare and orphan disease patients. Prior to joining Ultragenyx, Paul held positions with Genzyme, Express Scripts, and Shire. He came to Ultragenyx in 2016, where he began building the patient services group. He is here today to address the UltraCare program. We know that you're all looking forward to this information. So, Paul, thank you so much for being with us today.
Thank you very much. Thanks for everybody for joining the call. Thanks for the physicians for presenting at the beginning. I feel that at that point, a lot of questions will probably arise of, what does it look like, now that I want to start therapy, now that we have a therapy approved. And that's what I'm here to discuss, to let you guys know what UltraCare is and how Ultragenyx uses the UltraCare program patient services to assist patients and caregivers and families. We're a one-on-one personalized support service that will help out with disease education, insurance aspects, administration of the product at the correct site of care that you and your physician have decided to go down. What does it look like for sort of compliance? How do you make sure that medication can be where you need it to be, when you need it to be there? And we are a team that is made up of social workers like myself, healthcare professionals, and patient advocates. We have a team here at UltraCare of 8 folks. We have an average of about 10 years experience throughout the team who have been assisting patients in a patient advocacy or pharmaceutical reimbursement or patient case management experience for a number of years. We will work with you or your caregivers and family members to review your current insurance information, your benefits. We'll negate eligibility for any copay assistance or other patient assistance that may be out there for you, that may help with covering out-of-pocket expenses, which include administration, coordinate product shipments and home nursing services as needed. And we'll also work with those who may be on the clinical trial to how to move from clinical trial product to commercial therapy. So I wanted to just let everybody know that the program is free of charge. It's not, Ultragenyx is really extremely patient-focused, and, as a social worker, it's a reason I joined this organization. We believe as an organization overall that, we are here to help and assist patients. And as we go through the services that we offer, I hope that you that as well. So how do you enroll within patient services at UltraCare? Well, we are a physician-driven program, and it requires what we call a start form. And on that start form is an authorization from a patient and an authorization from a physician for us to start working on your behalf to gain access to therapy. That form can be found on our website. You can download it, you can fill it out, you can bring it to your physician. You can ask your physician if they already have a copy of it, how to fill that out and how to get that into us. And as soon as we get that, what we'll do is a welcome call. We'll explain all of our services. We'll explain to you that we're going to do a benefit investigation, which means we'll look into your insurance to understand exactly how the medication can be covered, because there's different ways that it could be. We'll work through any prior authorizations. I know that, folks may think that, prior authorizations is kind of a scary topic, but it's something that we face, and it's something that we can overcome and work through with you to make sure you can gain access to that therapy. And we'll also make sure that we can work through, when we get the benefits back, we look to see what services may be the best benefit for you or your order. And we'll look to make sure that we, again, look to see is it the correct site of care that you and your physician have decided to go down. And we'll look again for adherence and persistency programs. So basically, like people like to go on vacation, and perhaps you're somewhere different. You're a snowbird. Somebody may be in college, going to and from, and we need to make sure that you can receive medication where you are at the time that it is needed. As I kind of quickly went over, is the insurance coverage, we'll actually look into your benefits, not just for the product itself to see how that is covered, but if there's a need for any physical therapy or durable medical equipment, we'll actually look into that for you as well. So you understand your full health insurance and full benefits for whatever the needs are that you may be facing due to the disease state. That we'll also, again, with the prior authorizations, we'll make sure that it's not just the prior authorization the one time that it is required, but they call them recertifications. And, every month, 3 months, 6 months, up to a year may be required. And we'll make sure that we stay on top of that for you and make sure that you can continue to receive product as needed. If you were denied coverage, we have an appeals program where we'll work with you to understand the appeals process with you and your physician. But we'll do it in just a minute. But if you were denied, how do you actually still access medication? And I'll get to that. We'll also look into alternative coverage search. Perhaps you don't have insurance and you're looking to gain access to insurance. Perhaps we can look into small group plans. Are you eligible for Medicaid, Medicare? Is there an ACA plan, Obamacare, as you may hear? Is there an ACA plan that you might be eligible for? Are there different just avenues? Do you have Medicare Part B but not a supplemental? There's different things that we can do to work with you to make sure that you have coverage that you need and that is right for you and your family. I kind of talked about before is, once we establish what those benefits are, we may be looking to see exactly then can we assist with any out-of-pocket expenses. So we have commercial insurance, okay? If you're working and you have insurance through your employer, it's non-government payer, so no Medicare, no Medicaid, no TRICARE. But if it was a commercial insurance, we do offer a copay assistance program, and that's for the medication and administration costs. So that would bring it your responsibility for the medication and administration down to zero. So if we went through the prior authorization process, you gained access to therapy, and however, there is a copayment for the product. We can work with you to make sure that you have we bring that cost down to zero. And if there is an administration cost burden for you, we can definitely work with that to bring that cost down to zero as well. That is for the commercially insured patients. But if you did have we do to a institution such as a 501c3. And that 501c3, may be able to assist, and we'll refer you over to make sure that, you know where to go for assistance with copays, with premium assistance, or incidental medical expenses. So having a relationship with you, we understand exactly what your needs are and what services that may be beneficial for you at that moment in time. We know services can change, just like life changes for everybody. So we'll always be there. We'll always happy to help and move through as we need it. One of the questions that folks are asking, maybe thinking about, maybe not asking, but thinking about is, all right, we have a new product and it's newly approved, and health plans may take a time to actually be able to look through and see if they will offer coverage for this medication. Before they can do they write a policy for it? Well, we've thought of that, and we wanted to make sure that patients who have, if that case, that is a scenario, we offer what we call Fast Start product. Basically, if you and your physician decide you want to start therapy and need to start therapy, and you want to start right away, and there is any delays with any insurance or anything to that effect, they want this therapy as soon as possible, we have Fast Start program. That is charge product, no cost product that can be delivered up to 2 months of therapy. So this time to work through anything that is needed. The administration would be down at the physician's office or an outpatient hospital facility, and you would make sure that we could get you product as soon as needed. If you had been on therapy for a while and changed jobs, you switched insurance carriers, and coverage was to be a small-term coverage gap, we offer a bridge program, and that's again to make sure that you never go without treatment once you start therapy. And if you know insurance, we want to be there for patients. We want to make sure that they can, no matter ability to pay, that's not a problem for us with Ultragenics. We want to make sure that we offer long-term, no-cost product for you as well. So some of the high-level services that we offer here at UltraCare. And our UltraCare guides is what we call them. You may have heard case manager in the past, but our UltraCare guides who work here at Ultragenics are regionally based. So they will get to know you. They will get to know the physician's office staff as well. They'll know the insurance plans that are in that area. They'll be able to help you navigate and whatever service is needed for you at that time. So like I said, it's right now probably trying to gain access to therapy, but, in a year, maybe you're looking to move. Maybe you're looking to change jobs and change insurance. Maybe life changes. It's going to college. Again, the snowbird aspect. We'll be there to make sure that we can offer any services as we continue down, as you continue through life. So, again, at a high level, we are, again, a physician-driven program. I ask you to go to our website, take a look. That's where the start form is. There's also on the website a stay informed with the latest information, so you could sign up for that. And as we have more information, we're more than willing to share that with you, whether you start treatment or you don't start treatment. Again, we want to make sure that we are here for patients and for any assistance that they may need. Again, this is high-level overview. I anticipate there will be questions afterwards. I'll be more than happy to address those questions as they come in. Very much, and I'll probably be chatting with some questions in just a little while. Thank you.
Paul, we are intending for questions to be presented after all of our speakers, so please bear with us. We get your patience. We're pleased to have Sara and Robert DeRaymer Jr. with us to share their experiences. Sarah's daughter was diagnosed at 3 years old as a spontaneous case. She was placed on burosumab 1 month after the diagnosis and has been in the drug trial for the past 2 years. Sara is also a member of the board of directors for the network, and we're happy to have her with us today. Joining her is Robert DeRaymer Jr. Robert is 51 years old and started in the trial in June of 2016. He had his first surgeries when he was just 7 years old. In total, he's had 18 surgeries, including hip and reconstructive surgery. He's a great advocate and a great volunteer with the network. Thank you both for being here to share your experiences. Sara and Rob, I am turning it over to you.
Thank you, Carol. I hope everybody can hear me. I got kicked out a little bit ago, but I hope everybody can hear me now. Let me know if you can't. I just thought Rob and I could go through a few of the questions we've seen kind of floating around on this. I'll ask the first question to Rob and let him answer, and then I will answer the question after that. So, Rob, what results, if any, have you seen from taking Crysvita on the adult side?
I've been walking around a lot more. I've been getting out and doing more. I'm a lot less stiff when I get up. After sitting for a while, I can get up and walk easier instead of having to get my bearings straight. Step easier. I use a lot less now than what I used to. I used to use it around my apartment. I just didn't feel safe, or I just didn't feel good walking. But now I came in my car and I only use it for long walks if I'm, out somewhere, or if I go for treatments, walking around the airports or different situations like that.
From the child side, my daughter started at 3 years old and is now 5 years old. So just a little background, she'd not been on any real medication before that and was diagnosed very shortly before getting into the trial. The things we've seen since being in the trial, the bowing of her legs has, in my mind, improved significantly. More comments or questions from people about how she walks. Most people don't, even if they didn't know, they wouldn't know to ask about her having anything. So she looks just like all her friends, walks and runs just like all of her friends. One time she even told Dr. Carpenter that she was able to beat some of her friends in a foot race. Decreased pain, while a 3-year-old can't always tell you a whole lot about pain, she has had a lot of decrease in pain. We don't hear so much about her knees buzzing or hurting, pretty good on pain. I know that's one thing. I have talked to some of the other parents in the 5 to 12-year-old group as well. They've noticed a decrease in the bone pain, and it's not complaining as much about that. And her height, she went from falling off of her growth chart to, as you saw in the doctor's discussion, she's now, still on the small side is a lot closer to most of her friends. So those are some of the things we've actually seen during this time. One of the questions, Rob, was how long before you noticed anything, any changes after you started taking this drug?
I actually had to be within the first 3 or 4 months. I noticed I wasn't as stiff and achy, and because of my hips being a little out of whack, I used to get back spasms if I moved a certain way, and those subsided quite a bit.
From our perspective, I think people who didn't see my daughter as often noticed a lot quicker than I did. When you see somebody every day, you don't notice that they're walking differently, I guess. It took me about a year to notice, but we got comments within about 6 months of her being on vacation that she looked differently. She looked like she was getting tired, and that she was didn't appear to be laboring when she walked. Difficult. So, questions we've had also is what are the shots like? So, Rob, if you take that from the adult side.
I mean, it wasn't really more than like having a blood test or a flu shot or something like that. They weren't bad at all. I mean, 2 in the abdomen and 1 in the arm. Because I know that with the volume injection, it goes by body weight. I'm about 150, 155 pounds, so that's had the 3 different injections. Some weighs a little more or a little less. That could differ for them instead of having 3.
A 3-year-old, now 5-year-old, don't typically like shots. I know in talking to some of the parents, at least one of the parents in the 5 to 12-year-old study, her daughter hasn't really minded the shots, doesn't think they're necessarily painful depending on who gives them. My daughter's been a lot more hesitant. She obviously gets nervous about when she knows it's for her shot, doesn't like them, does think they're painful. But I think it definitely depends on the kid and the person on how painful they think they are. Everybody has different tolerance levels. I've noticed some kids have taken them better, and she does okay. We find ways around it. So, question, Rob, was how where the shot is administered.
Well, for me, it was, like I said, they did either upper abdomen in the back of the arm. I'm not the way they had to administer them. It's the arm yourself, because they had to pinch the fat and the muscle on the back of your arm to give it to yourself. So they will change that to maybe the upper thigh or something. I'm not sure, but for me it was 2 in the abdomen and 1 in the arm.
In a children's study, we went through, and the options were the arm, so the most of the upper arm, and then the thighs, and then the stomach. My child does not have a whole lot to her stomach, so we never chose to go in that spot, but we did try to rotate between the arms and the legs. I know some of the kids from, at least one of the moms I talked to, typically try to go with the stomach and thought that hurt less. I'd heard, but we rotated around at least 2 different spots. The next question we got, I don't know about for adults, Rob, but for the kids, making the shots any easier. Personally, we used a lidocaine cream before the shot. I've heard use what's called a buzzy, which is a tool that's supposed to, it vibrates and it has a cold pack and hopefully tries to get a little easier, less painful. And we do different techniques during shot with my 5-year-old to counter different things like that to get her through. If she did it. Other people, the kids don't worry about it at all. They do it, it's done, and they're on to the next thing. One of the questions we have here is, I'll ask you, Rob, any side effects that you experienced?
No, I had no side effects at all, no problems with anything. So for me, no side effects.
From our perspective, the difficult question to answer when I saw that one come through. In the study, we were asked to write down and keep track of every cold, flu, runny nose, ache, pain, or any other thing that you had, and kids get sick, and go through those things. So for 2 years, we've been keeping track of all that. It's difficult for me to say whether there was or was not a side effect. My child did have an abscess tooth during the study. I can't affect her if it's just part of being having XLH. One thing, I did notice a little bit of a runny nose after she would get her shot for a day or so. I don't know if it's related or not. And then another parent I did talk to, they had their daughter had hives and would itch a little bit or at some amount, but usually they would use a low dose of non-drowsy allergy medication before the shot, and that seemed to work fine for them. So those are what we noticed, and we remain in the study to date. And Rob, I'd ask you if you share, we remain in the study continuously at the time.
Okay, I know it's helped me quite a bit, and even just the way I'm feeling, and for the ease of having this shots once a month compared to taking 6 or 8 or 10 pills a day, like I do since I was growing up, it's definitely a lot easier, a lot more convenient, and I know it's helped me quite a bit.
Those are all the questions I saw that were submitted where it could be answered for patient experience. If you have any other questions, I'm sure you can send them to Carol, and we'd be happy to answer them.
Thank you both very much. I know that it makes a huge difference to others in our community when they can hear firsthand personal experiences from those that truly understand this journey. So I want to thank you both again for sharing your experiences with us. We have some time for question and answers. I don't see anything that has come through yet, so I'm just going to throw out a few of the questions that were emailed to us before the presentation just to make sure that we are addressing them. So I want to send this question to Dr. Carpenter and Dr. Insogna, and I apologize if this seems repetitive, but I want to make sure that we are addressing it. We had questions about calcitriol and phosphorus, whether it completely replaces that treatment, does it supplement that treatment, and how long, if it replaces it, how long do you have to be off of it before you can start the new medication?
This is Carpenter. I want to be clear that you can't do both of these therapies at once, because the amount of phosphorus that we were giving people when we were dealing with a kidney that was defective was really enormous. So once you fix the kidney, which is the antibody does, you can't do that, or else your phosphate level will stand at risk to become very high. we give the doses of phosphorus that we use to treat. So it would be entirely contraindicated to use these drugs if you're on the medication, if you're on the conventional and trial medications. Now, that being said, the meds wash out pretty fast from the system. That's why we had to give them so frequently when we were treating you with those. And so I believe you're probably fine in about a week. There might be a 2-week period that's designated in the in instructions, but I think you could probably go on the antibody within a week, and no longer than 2 weeks after stopping others. If you happen to go in the other direction, that is, if you get the injection, see that lasts up to 4 weeks. So there would, for any reason you had to stop and go on these medicines, since the injection would be longer, probably roughly a month or so, given what we've seen with these studies. But we would have to sample the blood to check to see that things were appropriate to consume the medicine.
Great, thank you. Then we've had a few questions presented to us about the guidelines under which someone could be considered a candidate. Is it appropriate for older adults? Why is it not appropriate for children under 1? What specifically will be looked at? Age, test numbers, severity of symptoms. I don't know if there's anything that you can share that might answer those questions, but we have a few similar ones.
The lower age range, and Dr. Insogna will address the older, but the reason the 1-year-old directive is in place is because that's really the youngest child studied. The study showed you data from was from the first pediatric study, and children were 5 to 12 years of age at the time of entry into the study. When that was looking promising and safe, a second pediatric study was started, and that's the one that Sara was describing that her daughter is participating in. And the age range for that study was 1 to 5. So the experience with this first 2 childhood studies is not younger than a 1-year-old. So there's, I think, primarily a level of caution that and lack of experience with it to do that. Now, that being said, I think that we often start therapy by 6 months of age. That would be useful to, under species of a research protocol, be to look at a younger age group treat. We often treat with other medicines at some earlier age. So I think it's shown that we're okay in those lower ages. I think it's a future directive that we'll probably be looking at. And for the older age group,
this is Carl Insogna. So the use of this medication in adults, its effectiveness in adults is based on that I shared with you, and that's the reason it was approved by the FDA. The who should treat it, I think, is in my mind considered in sort of 3 parts. First, if you are an adult and you are on conventional therapy, and you find that therapy you believe is helping you, it would seem reasonable to me that you could confidently assume that the drug, burosumab, will provide you with at least, if not better, results than the conventional therapy. And based on what you heard from Robert and based on the data I showed you, I think the data bear out this expectation that you would feel at least as good, if not better, on the drug. If you are an adult and you're not on the drug, who should get the drug? Well, Dr. Carpenter and I wrote a guide for conventional therapy a few years ago, and as I've struggled with this question, it seems to me that as a first pass, same kinds of recommendations we made in that paper would be reasonable guidelines for who, as an adult, should receive the drug. And those groups of individuals are those who have bad symptoms that they find are impairing their quality of life, loss of pain, loss of stiffness, weakness. People find that these symptoms are impairing their quality of life. I think would be very reasonable candidates to try the drug and see if it improves how they feel. The group are patients who have chemical abnormalities, patients who have very, very low blood phosphate, very high blood alkaline phosphatase, which, as you know, is a marker for soft bones. They might have an elevated parathyroid hormone level. Patients are patients that I usually start on conventional therapy, and those would be patients that I would be pretty enthusiastic about trying on Crysvita. And third group are anybody who's had a skeletal complication of the disease, an acute skeletal complication. Somebody who's gotten a fracture would be absolutely, I think, imperative that they go on this drug. And someone who's about to undergo skeletal surgery, let's say for an osteotomy to correct bowing, or because they were in a car accident and they had a fracture and they're not on therapy. Definitely those would be patients who I would recommend treatment. So those two categories of people I think are pretty easy in my mind and pretty straightforward. Answered is what to do with your 18-year-old who's on their way off to college, who the pediatrician stopped therapy at age 16, and they seem perfectly fine at 18. And before, the disease never goes away. As Robert will tell you, as you get older with this disease, the burden of the disease increases. You get calcifications around ligaments, in ligaments and tendons. You get fractures. You get osteoarthritis. So we know that this drug improves the bone quality. We know that it helps to heal. We say, based on the data, that it's going to prevent enthesopathy. It's going to prevent these fractures. So I think an open question. I think it's going to have to be an individual decision made with your physician or your endocrinologist and the younger individuals. As I think most of the adults on the call know, well, not invariably the case, there's kind of a honeymoon period between your late teens and your 20s and 30s, particularly in women, for childbearing age, and in men in those age groups. People are pretty good. A lot of them in college or post-high school are pretty active physically, don't really seem to have many problems. Then it starts to creep up on you in 30s and 40s. And by that time, you're starting to have some of these complications that are not reversible. So when is it that you cross a threshold where you should start? Should you have it forever? I think there aren't data to help guide us. So to my mind, the thing I said at the beginning are the things that I'm going to feel most comfortable with. I think in my younger patients, I think it's going to be on an individual basis. I'm going to be lowering my threshold for initiating therapy because the drug is much safer than what we had before. And I think since it's more convenient and much safer, that I will be more inclined to use it than I would not in younger people who otherwise I would have held off. But I don't think universally it's going to be for ever. I mean, I think we're just going to have to wait and see. If it turns out with longer-term follow-up that we are not seeing the thing I think is the most troublesome problems in adults, if we are not seeing enthesopathy, this calcification around joints, if we're not seeing hearing loss, if we're seeing adults remain more functional, is going to be a major argument for widespread use of the drug. One thing I'll say is, I can't tell you that this is directly relevant to this drug. We know because of studies that have been done at this institution by other investigators, the complaint that a lot of patients with XLH have had, which they feel weak, but with clinicians could never really objectively measure that weakness. People would say they just fatigued easily. For example, I have one of the patients in the study was a IU nurse, and she couldn't get through her shift without having to sit down. When she got on the drug, suddenly she had more energy. And they're all terms that we could not quantify in any way. People just subjectively felt better. They had more energy. Well, we now know that with a chronically low blood phosphate, the ability of your muscles to generate energy is impaired. So although we do not know this for this drug, we are suspicious that the reason why people have this sensation of more energy and feel like they have more tolerability. I had the other day tell me that he went to Rome and walked 25 miles in 5 days, and he could never have done that before. That kind of stuff we're starting to believe may be actually related to improvement in muscle function, and that too is something speculation, and we're just going to have to wait and see.
Great, much that we appreciate it. I wanted to ask a question. I think that this is probably best directed to Paul if he is still on the line. We're getting questions about who can prescribe the medication. Does it have to be a specialist? Can a PA or nurse practitioner prescribe it? I don't know, Paul, if you are the most appropriate person, but I will throw that out to you, and I'm sure you'll tell me if you're not the right person.
Thank you for the question. Typically, anybody can prescribe the medication. It does sometimes come down to payer-specific. You know, if their policy does dictate that a specialist does prescribe, that could be something. But I would say just talk to your the physician that you normally talk with, have them complete and send in a start form. And as we work through that process, we can work with you and that prescriber if there's any special anything special that's different about your insurance. But for the most part, it shouldn't be any problem for anybody who's able to prescribe. I will say, again, I've mentioned the website, but I did tell you the website. So it's UltraCareSupport.com, UltraCareSupport.com. And just, again, whoever your local leader is that you're working with, you can have them complete with you, and then we can work through the process with the three of us to figure out exactly what is the better for you as an individual.
And is there a telephone number that people should call?
Yes, there's also a telephone number. Yeah, 888-56-8657. Once again, that's 888-756-8657. And with UltraCare guides, more than happy to answer it, even if they're not, answer whatever questions you may have, even if they're not in the region that you may live in. And we can work through whatever, again, questions you may have.
Thank you. And I do want to mention one thing. I want to thank Sara and Rob again for sharing their experiences. I do want to mention that those are personal. The answers to those questions were from their personal perspective, and it's not meant to be an endorsement of the medication or any kind of clinical advice. Going through the questions that came in online, and it looks like I've addressed. But there is another question that just popped up about the administration of the medication, and I think that we touched on this, that it will be done at the office. Paul, is that correct? There's a question about whether it can be done at like a laboratory setting like Quest Labs.
So it's a great question. So whatever the physician, your physician and you decide is the best site of care, we can work through that. So if it is at the physician's office, it can be there. It can be at an outpatient hospital setting. It can be actually administered in the home injection services, where we do have very qualified. We work with home nurses who are very qualified in pediatric and specialty medications. So if it is an avenue that you and your physician are looking to explore, we can also work through home injection services as well. And it doesn't matter what, if for payment or not. If you're a patient who needs therapy and you are actually assured, we can work with you to try to also get the right site care for that you and your physician, even if that is a home setting. So.
Great. Do you have a couple of questions that are related that have come in that I will throw out to Dr. Carpenter and Dr. Insogna? I'm being asked, is this treatment a risk to kidney function? And also to touch on parathyroid disease, and is it safe for kidney transplant recipients?
We do have normal renal function. We don't have evidence that using this medication will have a negative effect on renal function or to deteriorate that. I think the other is another way question may be intended, and that is, if one has significantly impaired renal function, then with medication. At this point, there's an experience with that, and there is some theoretic rationale to believe that retention of phosphorus clearly can be part of impaired kidney function, could actually accentuate that issue. And so at this point, it's contraindicated to use the medication if you've got a significant degree of renal failure. So if you're healthy, we think you're fine. If you have impaired renal function, we wouldn't at this point feel comfortable giving you the medication. With respect to parathyroid hormone, the data on the use of drug over the course of over years now in patients with XLH has resulted in a very stable level of parathyroid hormone. So it hasn't influenced making the parathyroid hormone level go up or down. Studies have selected people that have not had dramatically high PTH levels. So there's someone that has an exceptionally high parathyroid hormone level. There might be reason to believe that therapy to lower it indicated prior to using this medication, but at this point, we don't have any evidence that the drug itself will alter the pH levels. The use of transplantation is also been explored. Assume, I refer to a patient that had XLH and for complications had to have a renal transplant, and we're talking about treating someone that has XLH that happened to have a renal transplant. You don't have any experience with that, and I think until that's looked into in a more definitive manner, we probably wouldn't advise that. Dr. Insogna weigh in on that as well. Use of this for phosphate wasting reasons that may occur after a renal transplant, if does not have XLH, would also not be appropriate.
I agree. I think, oftentimes after transplant, renal function improves dramatically, though it oftentimes is not completely normalized and over time can change. So it would be, in general, probably none we would recommend. I think there might be circumstances in which renal function was perfectly fine and essentially someone had, a living-related donor so that you had a kidney that you didn't require immunosuppression for, and the kidney function was totally normal, and you were having problems with XLH. I think that might be an isolated event, an isolated circumstance where it might be reasonable, completely reasonable. Occasionally patients who have a perfect match kidney that don't need immunosuppressive agents. It's the immunosuppressive agents in kidney transplants that can sometimes paradoxically impair the kidney function. So these isolated circumstances, but I think in general it might be an area where you'd be somewhat hesitant to use it. I did want to comment on one other question that was raised, was whether this drug damages the kidney itself. As those of you who take conventional therapy know, there is a problem with calcification of the kidneys with conventional therapy, which can occasionally be a problem more than just an image seen on ultrasound. We did look at that in the adult study pretty carefully, and there was no trend toward a worsening of calcification in anybody's kidneys with the drug. It's reassuring that in the doses that we used it with the targets that we used, which is basically to keep the phosphate in a low normal range, we didn't see any progression of any calcification or any new calcification. That said, I think if, as a treating physician, I am going to still monitor people's kidney by ultrasound and still check their urinary calcium to make sure that it remains in a normal range on the drug.
Great. I have another question that I want to present to our physicians. There is the question, is there a risk of hyperphosphatemia or other issues with overregulation of FGF23? Hello?
Went from unmute to mute and started talking. But
I lost you. I'm sorry.
Yeah, no. So yes, there is concern of hypophosphatemia. Did not see in any child treated with this drug hyperphosphatemia. However, theoretically, that risk exists. If you directly inhibit the system that we reviewed at the beginning of the hour, you could see where if a superimposed phosphate load for some reason occurred in concert with inhibiting that system, we'd see how the serum phosphate level would rise. In the adult studies, there was some mild elevation in serum phosphorus, and that's why we think intermittent monitoring is important, particularly early on. We see this because some people may need a dose adjustment if phosphate level is on the high side. So back to there is definitely a risk, and it needs to be looked for, but it was encountered at a pretty low rate in these studies.
Only five patients out of 134 were a dose reduction. So it's a problem we're running into frequently. But as Dr. Carpenter said, it's something that you definitely need to, and you need to be cognizant of. But also, once you get to a dose where the phosphate's in the range where you want it to be, unless you dramatically change your diet, we have seen people suddenly have a shoot up in their phosphate. So that's the nice thing. Once you're on a dose that seems like the right dose, looks like that just stays as the right dose for a long time.
Great. I am going through the questions to see if there is anything that we have not today. And there is a common question coming up about treatment in other countries, and we know that the approval of Crysvita in the United States is very exciting, and there are a lot of questions being presented about the approval process in other countries. We, of course, will be monitoring this and providing any information that we have as it's available. We know that the European Medicines Agency did give approval for conditional marketing of Crysvita in children 1 year of age and older, and for adolescents with growing skeletons. This is wonderful news, but it was the first step in the process for the European Union, and as we get more information on its availability, we will be sure to pass it along. I also want to mention a couple of things. There is a document on our website that may be of interest and help to you. Our website is at xlhnetwork.org. There's a Q&A document on our website that summarizes some of the information that was presented today. And I also want to mention again that this afternoon is being recorded, and it will be placed on our YouTube channel. So if you do have loved ones that were not available to join us today, it will be available online shortly. There are questions that have popped in that we have not addressed during the segment, but I do want to mention again that if you do have something, you can email it into us at info@xlhnetwork.org, and we will do our best to get an answer for you. I do want to thank everyone for taking time out of your schedules to be with us today, to all of our presenters for being on the line with us and working with us to provide this very important information to the XLH community, and of course to Global Genes for hosting us today.